and welcome everyone to Great Plains Quinn Friday Focus for Health. My name is Stephanie Hansen. I'm a registered nurse and quality improvement advisor for Great Plains Quinn. I'm joined by my colleagues Susan Wilcox, Jennifer Lochner, Tammy Wagner, and Kelsey Olson. We want to thank you for joining us today. This Friday Focus for Health is hosted by the Great Plains Quality Innovation Network, the Centers for Medicare and Medicaid Services Quality Innovation Network, quality improvement organization for North Dakota and South Dakota, and will focus on multi-visit patient MVP and reducing preventable emergency department visits. To make this interactive, please use your web cameras if you have one available. Today's webinar is being recorded and will be posted within 1 to 2 business days on our website at greatplainsquinn.org under the Friday Focus for Health link that we will also share with you. If you have questions, please add them to the chat. We have added a resource handout that you can access. This resource handout includes all resources and shared during today's session and will be added to as the 4-week series occurs. All right, helping the MVP, multi-visit patient. Helping the MVP will help reduce the cost and time of the emergency departments. As a reminder, we are trying to change the language around the super utilizer, frequent flyer, kind of et cetera, the things that we have used in the past, to change it to MVP or multi-visit patient. Readmissions are costly to hospitals, patients, and payers, and reduce patient care outcomes and satisfaction. In addition, an estimated 27% of readmission could be prevented with proper communication between healthcare providers and patients. It is alarming to hear that 27% of readmissions could have been prevented. It's not only costly and diverts time away from the medical staff to care for others, but take the perspective of the patient. Most patients have anxiety and are fearful of their own situation and don't know where to go to get help, so they end up in the ED. Like we heard from Susan last week, sometimes it only takes an additional 5 minutes of educating the patient, provide a listening ear, and giving them support to prevent them from an unnecessary trip to the ED. There's a multitude of barriers that increase the MVP to end up in the ED. As I mentioned, fear, anxiety, lack of resources such as transportation, lack of knowledge, homelessness, loneliness, and the increased rise of mental health issues. This is why I'm excited to hear from our community health worker in South Dakota and how life-changing their involvement can be for patients and decreasing ED visits. So I want to welcome Alyssa Olson. I will introduce her. Alyssa became the first community health worker at Brookings Health System. She helped create the program starting in January 2022 and began seeing patients when it was launched in March of the same year. She holds a BS in Community and Public Health from South Dakota State University and completed Community Health Work certification at Lake Area Technical Institute. She has also served as an EMT, conducted educational classes, and has traveled to several countries developing a love for different cultures. If you want to read more, we added her bio in our resource document. So thanks again, Alyssa, for joining us today. Excited to hear from you.
Thank you so much for the introduction, Stephanie, and for the opportunity to share at today's webinar. I just wanted to take a minute to also thank all the attendees for logging on today and taking time out of your day to learn about this topic. I do have quite a bit to go over today, so I'm going to go through pretty quickly, but I believe there'll be some time for question and answer at the end. And I will also share my contact information if anyone would like to follow up after today's presentation. Next slide. I want to start by briefly touching on what a community health worker is, since it's a relatively new profession in the state of South Dakota. A community health worker, also known as a CHW, is a frontline public health worker. They are trusted members of the communities in which they live. They typically share some of the same life experiences as their patients. They're dedicated to building relationships and connecting with others. They link patients to healthcare services, social services, and community resources, and they also act as a patient advocate and accountability partner. Next slide. As mentioned, the program here at Brookings Health System was developed beginning in January 2022 and then launched in March of the same year. The goal of our program here is to improve patient outcomes by reducing their readmission rates. For inpatients, readmissions count if they return in under 30 days, and then for our emergency department patients, under 72 hours. I focus mostly on frequent ED utilizers, otherwise known as MVPs, the multi-visit patients that you were referring to, and inpatients who are discharging home with a high risk of readmission. Referrals to our program come from the providing physician or a PCP, but they can also be initiated by both case managers and nurses. Whenever possible, I do begin my work by completing a consultation with the patient while they are still in the hospital whenever possible, like I mentioned. This just really helps build rapport and start building trust before they even leave our facility. I do mostly home visits, but I am also able to meet with patients here at the hospital or other community locations or even by phone if needed. Next slide. I've got a little bit of data here for you. As you can see, the majority of referrals to our program do come from the inpatient unit, but we have quite a large portion from the emergency department as well. I recently started taking referrals from one of the clinics in town, so that is still a relatively small referral source, but we do expect to see that grow. Some of the things that we've seen with readmissions as of March of this year, one ED patient had 2 readmission instances in under 72 hours while part of the program. And then out of 48 patients whose 30-day goal had passed, only 4 had readmissions in under 30 days. I also like to mention that I do work with a whole age range. As you can see, my youngest referral so far has been 6 months old, and then my oldest was 94 years old. Next slide. In today's presentation, I will identify problems that lead to emergency department overutilization. We will discuss resources and methods to promote proper usage of healthcare services, and then we will end with a look at a few case studies. Next slide. In order to explain how CHWs support the proper use of healthcare services, I think it's important to discuss some of the reasons healthcare services are being misused, and more specifically today, emergency department services. In my experience with patients, I've seen 4 common reasons behind emergency department overutilization: lack of overall knowledge and understanding, fear of being denied services from lower levels of care, undiagnosed and mismanaged mental health conditions, and loneliness. Next slide. Lack of overall knowledge and understanding can be addressed by CHWs through providing education to patients. Many patients simply don't understand the difference between levels of care and when it's appropriate to utilize each. For example, the emergency department versus urgent care versus primary care. These patients require education on what constitutes a true emergency and what does not. CHWs can also provide education to these patients on why chronic conditions are better addressed in primary care. I have had several patients ask me why they should see a PCP at a clinic when they can just go to the ED for care. For these patients, I provide education and explain the benefits of building a trusting relationship and seeing a consistent provider for those chronic conditions. And then I go on to explain to them why this tends to lead to better health management and treatment. There are other patients who know they should be getting primary care from a clinic, but they don't know how to establish care with a PCP. In these cases, CHWs are able to help facilitate this by providing the patient with local options, helping them schedule an initial appointment, and even assisting them with some preliminary paperwork at the clinic. Next slide. Patients' fear of being denied care can have several causes. This may be because they're in the country illegally, maybe they don't have any insurance, or they're just unable to pay for services. It is generally well known that patients will never be denied services from an emergency department, which is many times why these people seek care from the ED for all of their needs. Education, of course, in this case is also part of the solution, but CHWs can also facilitate appropriate use of healthcare services by helping these patients apply for health insurance, sliding rates at certain clinics, and maybe just financial assistance in general. As a CHW, I do on occasion act as a liaison between patients and billing departments to help assist in setting up payment plans. And all of this in conjunction with just helping them establish care at a primary care clinic helps them get them out of the ED and into appropriate levels of care. Next slide. Mental health can also greatly affect physical health, and when patients are undiagnosed or mismanaging their mental health, they can easily misuse healthcare services. These concerns can be addressed by CHWs through assisting patients in overcoming stigma to seek care for their mental health. I do this many times by just building a trusting relationship with the patient and providing education in general. CHWs can also make behavioral health referrals and suggest appropriate support groups for the patient. They can also act as liaisons between the patient and their PCP, if they have one, to request a mental health and medication check-in. This helps facilitate continuity of care. Many times, I also act as an accountability to patients regarding their treatment plan. Consistent medication compliance is often part of my work. I help assist patients in establishing daily routines and implement tips and tricks to help them stay consistent with their medications. I also help encourage healthy coping strategies. Next slide. Sometimes the most complex patients are those who are seeking healthcare services solely due to loneliness. They might feel comfortable, cared for, and understood in healthcare settings, and therefore they overuse the services in order to not feel alone. I feel like this is also just commonly seen in the emergency department specifically. CHWs can address this by making referrals to companion services and support groups. I also help facilitate community involvement by providing patients with up-to-date community events and opportunities for them to create connections with others. Overall, I feel as if these patients benefit from assistance in creating and building a strong social support network. If patients find purpose, community, and companionship outside of the healthcare setting, their misuse of healthcare services tends to decline. Next slide. We're going to move on to 3 different case studies now. These are just a review of patients I've worked with in the past. I'll start with kind of a little information about the patient in general and why they were referred, and then talk about some of the interventions we did and then the results that we saw. This case study number 1 was a middle-aged individual. They were living alone, recently had lost their spouse. They were referred due to failure to thrive. They had multiple chronic health conditions. They were non-compliant with medications and not checking their blood sugars regularly. They had a history of no-shows to follow-up visits. They had several recent emergency department visits. They had a long history of refusing preventative services that were offered. And by long history, I mean a clinic had been working with them for a couple years to try to get services into the home. They did not want people in their home, and we later found out this was because they struggled with hoarding. Next slide. Some of the CHW's interventions with this patient were after receiving an ED referral for them, I did make contact. After that, I wasn't able to make contact with the patient again, but they came back into the ED, and that time they were sick enough that they were actually admitted into the hospital. So due to the barriers I had experienced with this patient, getting in contact with them in the past, What I decided to do was what I call an extended consult with this patient, where I met with them prior to discharge for about 30 minutes and kind of went through some things to help increase those chances of connecting after they left. I really worked with this patient strongly on building rapport and trust. During this hospital stay is when they had admitted to their struggle with hoarding. So I made sure that I encouraged them and recognized how huge of a step that was that they took and how big of a deal it was that they actually had put that into words and voiced it out loud. Really worked with them to break down barriers by connecting with them on a personal level and sharing some personal experiences with them. We did take some time to talk about some of the feelings that they were having, like shame, guilt, and fear. And then prior to leaving their room after the consultation, I made sure that I reinforced the benefits of skilled home health services. And I educated them also on the importance of attending all follow up visits to help decrease the chances of ED visits and hospitalization in the future. My primary role with this patient really was connecting with them while they were in the hospital and making just really building some of that trust and making that connection and personal interaction with them. After I left this consultation, I did get a call and found out that shortly after we had visited, the patient ended up accepting all of the home services that they had been offered, which was really exciting after, 2 years of churning it down. Just really getting on an emotional level with that patient and relating to them can make such a big difference. Next slide. So, like I said, with this patient, a lot of what I did was actually in the hospital before they went home, which is different than most CHW work. I did do a couple home visits with them, but physical therapy, occupational therapy, and home health also got involved and did a lot of the work. There was some family involvement as well. And through all of this, the patient is now regularly taking medications and checking their blood sugars. They're regularly seeing a mental health counselor. They're attending all their doctor's appointments. They're getting help with cleaning their home. They're wearing clean clothes because they're able to do laundry again. They're enjoying repaired plumbing. They're able to take regular showers and baths independently. They are set up with an emergency response system. They have hot meals delivered daily. And they have actually started driving again as well, which is a really big deal to them, really improves their independence and even being able to get to those follow up medical appointments. And as a result of all of this, they're no longer frequently using the emergency department. Next slide. Case study number 2 is a young adult. They were not established with a primary care provider. They were using the emergency department as their primary source of healthcare. They were recently homeless. They had seen a significant recent decline in overall physical health. They even had mobility concerns that were getting worse, walker usage about 100% of the time. They really had no social support network. They were unemployed and no health insurance. Next slide. Like with all patients, my work started by building trust over time. I did that with this patient by providing a lot of tangible support, such as food referrals. I did get them some furniture after they were set up with housing, some prescription medication assistance. With this patient, I did a lot of educating them on the different levels of healthcare services and appropriate times to use each. Again, as an example, the emergency department versus urgent care versus the clinic. I provided education on the importance of establishing care with a primary care provider. I assisted them in selecting a clinic, provider, and getting an appointment scheduled. We filled out sliding fee applications as well as health insurance applications. And then I also encouraged the patient to start building a social support network using community resources. Next slide. In collaboration with behavioral health services and case coordinators on this patient's case, we were able to establish a primary care provider. They are no longer seeking primary care in the emergency department. They are receiving sliding fees at the local clinic. They're awaiting health insurance application review. They are attending community activities. They're part of a strong social support network and recently told me that they had made a couple really close friends. They're no longer homeless. They have a furnished apartment. And with this person, one of the most exciting things I think is how addressing those social stressors has actually improved their physical health, as in they're no longer using their walker. They've said, I feel so much better that I don't need this anymore. I feel more confident, more strong, just better able to handle daily life. They're also employed, receiving food assistance, and seeing a mental health counselor. Next slide. This is our final case study. This was an elderly individual who was referred due to failure to thrive. They were malnourished, weak, long history of falls. They had inadequate in-home assistance, multiple chronic health conditions, medication noncompliance. They did have supportive family and friends, but they were lacking care coordination amongst them. Next slide. For this patient, I started with some in-home service referrals. I also did a referral to a pharmacy that does medication bubble packs to help with the medication noncompliance. I reinforced tips and tricks to improve their nutrition and weight gain that the dietitian had given them. I did a companionship referral. This patient did have some at-home vitals equipment, so I did some education on proper usage of that. A referral for an emergency response system. And then this person was a little bit unique because what I ended up doing was facilitating a meeting between the patient, family members, and workers to help get everybody on the same page and really coordinate care efforts with the patient. Next slide. The results of working with this patient is an increase in their medication compliance. They did gain weight and maintained it. They do have regular in-home services now. They have daily coordinated support from family members now that everyone knows what their role is and what they're responsible for. They've had no recent falls. They have an emergency response system set up. There's overall improved communication between the patient and their support network. They've had no recent emergency department visits or hospitalizations, and this patient's actually seen an improvement in their memory and morale. And family members have also said that they've seen an improvement in their memory and overall well-being. Next slide. And that's the conclusion of what I have to present today. My contact information is there on the screen. If anyone would like to follow up after today, you're more than welcome to email or call me.
That's great, Alyssa. Thank you so much for that presentation and sharing your case studies. I think that was really informative. And I guess a big takeaway for me is just, really the trust and that building up of relationships that community health worker can provide, and what a significant difference it makes in the lives of our patients, and preventing them from getting into the ED and living a more healthier, successful life. So that is just great information. So I'd like to open it up to one question. I'd really love to open up and just see, well, obviously, if you have any questions for us or Alyssa, we'd love for you to come off of being or talk and chat, or come off of your mute, come off mute and talk to us. So we love that. And otherwise, in the meantime, I would just like you, if you could, place in chat, in your organization, are you currently using the community health worker? If you just want to put yes or no. I'm just curious, throughout our states, if anybody is actually actively using the community health worker, that'd be great. And we'll just give you some time to just type that in chat, if you don't mind just putting a yes or a no for us to know. And if you would like to come off chat and share any good work or anything that you are doing, please do that also.
I'm seeing some no's so far.
Okay.
We had a few questions before that too.
Okay. Well, I think we can go ahead. We can answer the questions in chat here, Jennifer.
Rebecca said, first of all, great work. Thank you. How many CHWs does your employer have?
That's a great question. For now, we still only have myself. So I am the only CHW that people are referring to within Brookings Health System.
And then Lisa asked, what did you use as a guide to set up your CHW program?
That is kind of a tricky question. We were one of the first hospitals to start a community health worker program in South Dakota. So there really wasn't a lot in South Dakota to use as a guide to set it up because there weren't any of these yet. So I really relied heavily on the South Dakota Collaborative of Community Health Workers because they've done so much research of outside states that were already doing it for years. So really relied heavily on them. I also made sure to network and connect with a lot of people in other states like Minnesota and New Mexico that already had community health worker programs. So really, we just kind of compiled all that information and looked at what our goals were and talked about kind of how to meet those goals. And we kind of had a loose framework in place when we launched the program and really left it open to making adjustments as we went because we knew that was going to be important to be able to fine tune things as we went along since we weren't really quite sure exactly what a community health worker program meant in this state.
And
Okay.
Lori
That
said,
answered your question.
Lori said, the takeaway for me is working to alleviate loneliness and providing just that extra attention to help client feel confident and that someone is paying attention and listening to them.
Absolutely. A lot of the feedback I've gotten from my patients is we just really appreciate how you are not rushed. And we all know that the demands on healthcare settings are a lot. And providers really they just don't have that time. It's not something that they're able to give patients is a lot of time. And so as community health workers, it's nice to be able to give them that time. And I really make sure that I try to focus on not rushing people and letting them have the time to explain their concerns and focus on some of those relationship building things. Absolutely.
And then Terry asked who and or how to reach out to find out what is in your community.
So I'm guessing you're asking kind of resource wise. Is that correct? If you just want to put in the chat, just so I make sure I answer the right question here. Okay. So I grew up locally, so I had a decent knowledge of what was here, which is a lot of times why people do try to hire community health workers that have lived in the community for quite a long time. Also, part of the certification classes I took were looking into some of the resources that are local. And even beyond those classes, I spent a lot of time I would just drive around and stop places and meet people and chat with them, set up meetings, all sorts of different things to try to get a really good idea of what resources are local. It's a lot of just kind of going outside the box, and just making those connections, calling places up. Hey, United Way, what exactly do you offer? Call the food bank and, see if they offer anything other than food resources. And I do keep some files kind of myself of pamphlets and stuff that I can hand out to patients. And there's always new resources. So just a lot of networking. And 211 too is a great site in the state of South Dakota that you can always go to if you don't know what resources are available or if you need like an update on resources too. I do also use that.
I guess I have a question to Alyssa. What would be the best way for, someone on this call that might be thinking we had a lot of no's, they aren't working with a community health worker. So what would it be to get them to be able to incorporate a community health worker? I mean, I know money is always an issue too, but what, what would be their first step to maybe see how they could incorporate the community health worker within their organization?
Yeah, I would just start having some of those conversations within your organization. I would, attend things like this and hear stories from other places that have incorporated them, because I think a lot of the incentive to get community health workers in your organizations come from talking with other people that already have them. I'd also suggest reaching out to the South Dakota Collaboration for Community Health Workers and get some information from them, because they've been really helpful with starting programs. It really all just boils down to creating relationships, with providers, with staff in different departments, with upper management, really just creating relationships and figuring out if this would be of value to your organization. How would it be? How can we go about this? And really kind of just taking that leap of faith, honestly. Don't expect to have it all figured out before you start, because that's not how it's gonna be. But it's been very exciting.
And what an asset you are, Alyssa. What a great community health worker. You're
Thank you.
really doing a great job. So thank you.
Great to see that. And it's great to see the best practice of what you're doing so others can, look to that or towards that and see how it can maybe work within their organization. So we really, really appreciate you being on today. And like we said, Alyssa said she'd share contacts. So I think if anybody needs to reach out back to Great Plains Quinn, to us to have any further questions or to Alyssa, that would be great. And we will add the link to the CHW of South Dakota, .org link in our resource too. And I think Lisa from North Dakota had added the, what's it called?
211. Yeah.
Yeah, like a
First
211 in
link.
North Dakota.
First
Yes,
link.
thank you.
Yep.
First link. I couldn't quite see it. So,
Yes.
yeah, so that was added in there too for our North Dakota people. So, this was great. I really appreciate everything. I know our time goes quick, and if there are any questions, we hate missing them. So just be sure to just email us back. Let us know what you have for questions, and we can follow up with Alyssa, or we can get that information out to you. So after you leave today, please follow up with us with anything that you're thinking of. And we do have an evaluation. So if you can please complete that, we really appreciate your feedback. And then if it's easier, you can just scan that QR code or click the link within the chat to complete the form. And as always, we value your feedback and want to make these informative for you. And we have a couple more in this series coming up the next 2 Fridays that we will continue to focus on the multi-visit patient and reducing ED visits. And we're excited to start giving out lots more tools that we have provided and come up with that we hope that we can hand out to you, and that are housed on our website. So we will look forward to meeting you guys all or seeing you all again in the next couple Fridays, if that works in your schedule. So I think that's it for us. I'll let you all go on this Friday afternoon and enjoy the weekend. Thank you so much, everybody.
Thank you.
Yes.
Thank you.
Bye.
Thanks again,
Thanks,
Alyssa.
Alyssa.